Very good morning, students. So, in the last class, we focused regarding the glycogen storage disorders. Now, let us move on to the next topic, that is diabetes. So, as you all know, that this particular diabetes or diabetes mellitus, it is also referred as, is not a one disease, but it is a heterogeneous group of multifunctional polygenic syndromes. It is mainly characterized by an elevated fasting blood glucose, which is mainly caused by a relative or absolute deficiency in the insulin hormone. See, nearly 26 million people in the United States who have diabetes. Of this population, that is almost approximately 7 million, out of that 8% of the populations are yet to be diagnosed. So this diabetes, which is nothing but the leading cause of adult blindness and amputation, which is going to cause a major renal failure, nerve damage, heart attacks, and even strokes. So, in most of the cases of this diabetes mellitus, which can be separated, that is, it can be divided into two groups, as you all know, that is type 1 diabetes. Formerly, it is referred as insulin dependent diabetes mellitus, and even type 2, that is called as non-insulin dependent diabetes mellitus. So, the incidence and as well as prevalence of this type 2, that is non-insulin dependent diabetes mellitus, which is increasing because of the aging of the US population, and even we can see with respect to this increasing prevalence of the obesity, and even it also depends upon the sedentary lifestyle, that is mainly because of this sedentary lifestyles. And we can also see this type 2 diabetes mellitus is majorly, we can see in case of children's, they are getting disturbed with this particular type 2 diabetes mellitus rather than type 1. So, what is this type 1 diabetes? That is called as I said earlier, that is insulin dependent diabetes mellitus. So, the patients are the person who are suffering from this type 1 diabetes mainly constitutes less than 10% of the nearly 20 million known diabetics in the United States so far. This disease is mainly characterized by an absolute deficiency of the insulin, which is mainly caused by an autoimmune attack on the beta cells of the pancreas. It is mainly caused by an autoimmune attack of the beta cells of the pancreas. In this type 1 diabetes, the islets of Langerhans, which are going to become infiltrated with activated T lymphocytes, which further leading to a condition called as insulitis. This is referred as insulitis. So, over a period of years, you can see this autoimmune attack on the beta cells, further leading to a gradual depletion of the beta cell population. So, however, the symptom which is going to appear abruptly, but when 80 to 90% of these beta cells which are going to be destroyed, at this point you can see the pancreas fails to respond adequately for the ingestion of the glucose molecule, and on that time that insulin therapy is mainly required in order to restore back the metabolic control and in order to prevent the life-threatening ketoacidosis. In order to prevent the life-threatening ketoacidosis, you have to make sure that insulin therapy is required. So this beta cell destruction, which requires both a stimulus from the environment such as viral infections and also a genetic determinant which follows the beta cells to be recognized as a non-self. They are going to be recognized as non-self. So you can see here, in case of this type 1 diabetes, as I said you now, because of the autoimmune attack, right? The beta cells of the pancreas, you can see the gradual depletion of the beta cell population, right? So how you are going to diagnose with this type 1 diabetes? So the onset of this particular type 1 diabetes, in case of your during childhood or the puberty, and this particular symptoms which are going to develop suddenly, the patients with type 1 diabetes, which can usually be recognized by the abrupt appearance of this polyuria. These are the conditions: polyuria, that is nothing but frequent urination; polydipsia, that is nothing but excessive thirst; and polyphagia, that is excessive hunger. So further, often triggered by physiological stress such as an illness. You are going to make out with this patient all these three conditions with an illness. These symptoms, which are usually accompanied by the fatigue and even weight loss, the diagnosis is mainly confirmed by a glycosylated hemoglobin. Glycosylated hemoglobin, that is also called as HbA1c. This particular concentration in those patients, there is a glycosylated hemoglobin, that is concentration will be greater than or equal to 6.5 mg per deciliter. That is going to be normal, less than 5. Normal person will be having less than 5.7, or even it can be, that is if you see in the fasting blood glucose condition, that will be greater than or equal to 126 mg per deciliter. So this fasting is nothing but how you are going to say whether the particular patient is suffering from diabetes by diagnosing the fasting blood glucose. It is nothing but a calorie intake for at least 8 hours. So this diagnosis, which can also be made on the basis of the no fasting, that is in case of the random, that is a random blood glucose level. If you diagnose, then you can have the comparison with respect to that random blood glucose level will be greater than 200 mg per deciliter in an individual who is suffering from hyperglycemic condition. The symptoms of hyperglycemia, there is nothing but more amount of the glucose concentration which can be observed in the blood, that is greater than 200 mg per deciliter. So when the blood glucose is greater than 180 mg per deciliter, so the ability of the kidney to reclaim glucose is going to be impaired. So further results in glucose spilling into the urine. So the loss of the glucose is mainly accompanied by the loss of the water, resulting in the characteristic polyuria with a dehydration and polydipsia of the diabetes, that is nothing but, what is it? Polydipsia, polyuria is excessive dehydration, right? So polydipsia is nothing but excessive thirst. So excessive loss of the urine. Further, of course, the patient will be having this diabetes will feel excessive thirst, feel to drink more water, and even at the same condition excessive hunger also will happen. So what is the metabolic changes which is going to happen in case of this type 1 diabetes? So these are the metabolic abnormalities with respect to this type 1 diabetes mellitus. We can see result mainly from the deficiency of this insulin, which profoundly affects the metabolism in three tissues, that is in case of liver, in case of muscle, and in case of adipose tissue. So what is this? What are those conditions? That is hyperglycemia. The patient will end up with hyperglycemia and ketoacidosis, right? And hypertriacylglycerolemia also. So what is this hyperglycemia? It is nothing but elevated level of the blood glucose, which we can see, and even ketone bodies can be seen, which are the hallmarks of the untreated type 1 diabetes mellitus. So this hyperglycemia is mainly caused by the increased hepatic production of the glucose via gluconeogenesis process. So via this gluconeogenesis process, there is synthesis of glucose, which is going to be done through this gluconeogenesis process, combined with the diminished peripheral utilization. So in case of the muscles and adipose tissues, you have this particular combined action which we can make out with respect to this gluconeogenesis with a diminished peripheral utilization, the glucose molecule in the particular insulin sensitive patients. So this glucose transporter, that is GLUT4, right, and also ketosis, who are going to the patient who is going to result from this particular ketosis, which you can make out increased mobilization of the fatty acids from the adipose tissue, which is combined with this accelerated hepatic fatty acid beta oxidation, right, and also the synthesis of 3-hydroxybutyrate and acetoacetate. These are all the ketone bodies which we can see. And also you can see here acetyl coenzyme A and beta oxidations, right, which are going to be the substrate for the ketogenesis process. We have already discussed in the last classes while explaining you glycogen storage diseases and other pathways. I have told you about this ketogenesis process, right, and the particular allosteric activator of this enzyme which will be responsible, that is pyruvate carboxylase enzyme, to activate this gluconeogenesis process to produce more amount of the glucose. So this is going to be resulting with respect to this high level of the glucose in the blood. So what is going to happen in case of diabetic ketoacidosis? It is also a type of metabolic acidosis which is going to occur in almost 25% to 40% of those newly diagnosed with type 1 diabetes, and may also reoccur if the patient becomes ill. Mostly the most of the conditions, that is most of the times, it is common with an infection or even the doses not comply with the therapy. Diabetic ketoacidosis is treated mainly by replacing fluid and electrolytes and administering short acting insulin to gradually correct this hyperglycemia without precipitating hypoglycememia condition. So you should make sure that you should take care of it without precipitating hypoglycemia. There should be no level of the blood glucose in the body without getting your blood glucose precipitated. You have to maintain this normal level of the glucose in order to correct hyperglycemic condition. So you can make out in this slide, this is the intertissue relationship, what is going to happen in case of type 1 diabetes, what I discussed so far. Tricarboxylic acid cycle, that is a TCA, that is through this you have acetyl coenzyme A molecule and very low density lipoproteins with a glucose transporter, right, GLUT4 T4 glucose transporter, how hyperglycemic condition is going to happen through the gluconeogenesis process, how these ketone bodies are going to be synthesized via the combined action of this glucose transporter as well as metabolic ketoacidosis, which is going to end up in hyperglycemic condition, that is a high level of the blood glucose in the body. So coming for the next disorder, that is I said you, that is hypertriacylglycerolemia is going to happen with respect to this type 1. This is the another metabolic change. So not all of the fatty acids which is going to flooded in the liver can be disposed of through this oxidation of ketone body synthesis, but these excessive fatty acids which are going to be getting converted to triacylglycerols, as I said you, that is TAG, triacylglycerols, which is going to be packaged further and secreted in very low density lipoproteins, that is VLDL. So these chylomicrons, which are also going to be synthesized from these dietary lipids by the intestinal mucosal cells only after a meal, because lipoprotein degradation is mainly catalyzed by, as you all know, that lipoprotein lipase enzyme, which plays a very important role in the capillary beds of adipose tissues, which is very low in diabetics. The synthesis of this particular enzyme is mainly decreased when the insulin levels are low. Lipoprotein lipase enzyme synthesis will be decreased only when insulin levels are low. So when the plasma chylomicrons and VLDL levels are going to be elevated, further it results in hypertriacylglycerolemia. That is nothing but increased level of fatty acids, ketone body synthesis. So this excess fatty acids which are getting converted into TAG, that is triacylglycerol. So it is going to end up in hypertriacylglycerolemia. So these are all the metabolic changes which is going to happen in case of type 1 diabetes mellitus. Next class we will see with respect to the treatment of this, how we are going to treat the patient who is suffering from type 1 diabetes. Thank you.